Kinawa, das naltoko. Jonas zede jonda ke kaleko. Yosemi kalini anda basis kesta anda iti anda basis konjondo ko. Yeni de cheko. İşe da şey tabalar. In Jesus' name, amen.
Amen. Thank you, Rydell.
Amen. Thank you, Rydell.
Thank you.
Amen. Thank you.
Thank you. Thank you so much for that prayer. I mean, it means a lot to all of us when somebody, especially when you have the honor to do the prayer for our meetings, because, you know, it does help us to open this meeting to ensure that we try to, you know, use those prayers to give us the strength and give us the motivation and encouragement to gain what we can from these meetings to be able to provide that support to our tribal members within our communities. So thank you for the blessing. I felt that all the way over here. Thank you, Rydell. So we'll go ahead and start this meeting because I know it ends at 12. I know my team has been really trying to get their presentations together. There's a little bit of editing that needs to happen to these slides, and more just the graphics. But the information that is on the presentations are more kind of the focus of this these meetings, and bringing any updates or changes, communication to you all. And a lot of the stuff that we're going over, I usually have the team go through the last quarter, what we've received, all the way from prior authorization requests, provider contacts, provider information that we receive at the access level, any member complaints, grievance and appeals that are coming to access, just to kind of keep a summary of what we're receiving all together so that we can provide that overall support to you when we do, when you're having questions or concerns, or if you go to a policy and you don't understand a certain policy, or you need clarity on a policy, or you just need some guidance. This is the time that my team really does go back and look at what has transpired within the past quarter, and where can we provide that support and a little bit more education at the leadership level, so that you as leaders are able to guide and assist your team members at your level, so that they can be in compliance. And the end result is that we ensure that members receive the care that they need in the tribal communities. And one of the things that we have been talking about quite a bit here is that we don't know the overall community services that are out there. We know that there are barriers. There are a lot of barriers out there at the healthcare level sometimes, and how you all coordinate those services. And within the tribal programs also, there are other benefits and other services and other types of community outreach that you all do to your members. I know that there are some health and wellness checks that happen. So with that being said, I think that, we all kind of work together as a team. So anytime that we receive any type of communication from a provider, a member, or even from a case manager, we try to relay that back to you all, because we want you to be in the loop of what's going on, and to be able to resolve some of these issues at your level. And you as leaders, you do oversee your case managers, so that you're able to provide that support, hopefully utilizing some of these tools that we share with you. And also maybe even at your own internal meetings, you could take some of these slide decks, because we do put them on the web, and utilize it to kind of assist your case managers. These are the changes, these are the updates, these are the concerns and issues that are going to the access level, because you really want to resolve some of these issues at your level, at the program level. You're basically the health plan, long-term care plan for these members. So within these meetings, we're creating more data, we're creating more for the supervisors, and for ourselves to kind of track our turnaround time of what we do here within access, and then also providing this information, not to hold it to you as I got you moments. Don't ever think that. We run these datas, we pull these datas together to kind of assist and guide you so that you can all be successful in your audits, especially now that we have an audit coming up soon. So just please, like Cheryl said, just enjoy. Hopefully you guys have a cup of coffee. It's going to be a 3-hour meeting. So if you do need to take a break, just make sure put yourself on, mute or something, and then and if you have your camera on, you can turn it off if you want, if you feel comfortable doing that. So it's really all up to you. We just want you to just, absorb all this information that we're going to share with you all. So, but first to start, we have a new team member, and we also had some internal promotions that has happened since the last quarterly meeting. You all know that Sonny Fisher has moved up to the management position. She's the tribal ALTCS manager now. Bandana has also moved up. She is now one of our coordinators. She's really has been working very well. She's really streamlined a lot of processes on the clinical side to assist the clinical nurse. So she has moved up. And also we do have, with that, we have a really good addition to our team here. Her name is Charlotte Little. She is Diné from Navajo Nation. She has a huge, maybe one day we'll have her present something, about her, of what she has done in the tribal community, not just in the state of Arizona, but other states also. So I was very, very impressed during the interview process. She brings with her a lot of experience. She's an internal hire. She brings with her a lot of claims experience, issues, and how to resolve some of these issues that she sees with claims, and navigating through the PMMIS system, which made it so much easier to train her, because she was very familiar with some of the screens. So we do have now, I feel, a really strong team. We're actually hiring for the tribal ALTCS nurse too, so that will be posted soon. So I'm hoping that, once we get the new nurse, at least Vanessa, she also promoted to, she's now the clinical nurse supervisor or manager for both the DDD population, the DDD ALTCS population, and the tribal ALTCS nurse, the nurses. So she oversees both programs, just like I myself do too. We inherited the DDD acute care services and behavioral health services and transportation related to those services. So that pretty much explains why it's been really hard for some of you to get in contact with me, but I know that Sonny and Cheryl has done a tremendous job, providing that support at that level to all of you across the board with all the plans. So I just feel like I have a very strong team, and I really appreciate all of them. And I also appreciate that you all have been going through them and trying to resolve some of these issues at your level and their level to ensure the members receive the services that they need. But so you can go to the next slide, whoever's running this. Charlotte, I think it's you. So within the past quarter, we've received quite a bit of member complaints, member issues. We had to educate on these member complaints, and we have at some point in time one of the supervisors has connected the member with us. It was a really big case where he was not happy with the services that his family member was receiving. They followed the chain of command. They went through the case manager, then the supervisor at the case manager level, then they went all the way up to that supervisor's manager, and then it came through Sonny, and then it eventually ended up in my area. So that whole process took some time of having to explain to the member. The member was not happy. The family member was not happy. The family member was naming everyone that he has tried to reach out to, knew their names, even the phone number, the date of contact, was very, very upset by the time the member got to my level. And at that point, we did explain, the case manager, the program supervisor, she did a really good job in trying to explain to the member of what the process is and, what is in the benefit for that member's long-term care services. So trying to explain that, she did a good job. There was a lot of documentation, and we did, provide some assistance and some guidance to not only the supervisor, but also the case manager, make sure everything is documented. The communication has to be documented. The information that you provide to this family member needs to be documented, and making sure and ensuring that your team members follow this process. So we did provide that one-to-one guidance, but that was not the first time it happened. It happened twice within this quarter. So I know that as a supervisor, it can become challenging when a case manager has tried to do their best to help and assist the member with the services. Maybe they're not satisfied with the services, maybe they're disagreeing with the services, but at the end of the day, they still have a right. Members have rights. And I think that's what we really wanted to focus on today, or my presentation is going to be about, is that members have a right. If they're not satisfied with any services, that they're receiving, they can file a complaint. And with that one case that went all the way to the manager, came to me, and I was involved in that, the family member wanted my contact information and who my supervisor's contact information was. I give that out to whoever has a complaint. If it's about me, whether I agree or disagree, or whether I did the best I could for this member. In my opinion, if I did the best I could, but they're still not happy with the information, I provide them my contact information and my supervisor's contact information. And then I follow it up with an email to my supervisor and let her know, hey, heads up, this is just what transpired. You might be getting a call pretty soon, or there may be a member complaint coming in with my name on it. But I'm just letting you know I documented everything, and this is the information that I shared with the member or the family member. So that kind of protects me to be able to provide that information. And it's always good to, if you can get the contact, maybe an email or maybe a letter to kind of just well, you do have the assessment that has been signed off on. If you know that the case manager has done their due diligence and they've looked and reviewed the case, and you agree with the decision that was made and you feel confident that it was made, then there shouldn't be an issue. If the member does have a concern, does have a complaint, then you should be able to say, you know what, if you don't agree, there is a process that you can go through. You have a right to file a complaint if you want. I'm not going to discourage you from that. You have a right, whether it's, if it's an SMI member, you have a right to file a grievance if you feel that that is what you need to do. But based on my assessment, this is what has been determined and this is what I see. So that is one of the things that throughout my presentation, I'll be reiterating, because it was quite a bit of complaints that we received, and there have been phone calls, but we've directed them to try to resolve it with the health plan, go back to you, make sure, try to reach out, what have you done? I've done everything, they're not helping me. And like I said, when it comes to them naming names, that's when we then have to kind of get involved and make known to the program. And sometimes it's just a member or a family member who's very upset, and that was the case with one of them. Just their lack of understanding, not understanding, and I did explain, do you have the member handbook? Because it is out in the handbook. So we did everything we could at our level. And then at the end, we just gave him the contact information of where he can file a complaint, our supervisor's contact information where the complaint can be filed. So with all that information, we gave it up to to that family member, just to let them know that, you know, we did the best that we could, you know, without getting upset, you know, without, you know, them feeling like we're retaliating in some way at all. So please just let your case managers know that these are coming to access, and we are sharing the information with them of where they can file these complaints, where the grievance can need to go to, because we're, like I said, this past quarter, we got a few of them. And I just want to just reiterate to all of you, just please, you know, get with your team members, your case managers, and let them know that members do have a right. And anyone on behalf of the member, you know, can report the complaint. They can complain to access. They should be going to you all first. Try to resolve it at your level. And I do encourage that your case manager do, you know, they document these phone calls, they document these conversations, so that way they have a history to go back to in the event that it escalates up to your level. And if it does escalate up to your level, what are you doing to make sure that those issues are resolved? So like I said, anyone can file a complaint, but the release of information, it is not needed to file the complaint for the member. But that would be needed if they need to do an outreach back to find out to get those correspondence related to that complaint. So that would be an education. If the member says, well, I'm going to file a complaint, here's the information. Okay, here's the information. But remember that they won't talk to you unless you have that release of information. If you're not the legal guardian of this member, or if you're not the member, they're not going to release any information to you. So make sure, you know, to educate whoever is complaining about this, because the more you provide to them, I think they back down and say, okay, well, really everything is in writing. The assessment is in writing. Everything was documented. So you know that your case managers will know that they did everything they could, you know, to ensure that the member have these services. And then also filing a complaint. This is one of the things that some of these members were saying, that I don't want to say anything. I don't want to go back to that tribal ALTCS health plan, the program, because they're going to retaliate. And every time we say something, these case managers, they retaliate. So those are some of the comments that we're receiving too. But any retaliation would be considered a violation of the member's rights. So if the member has a right not to agree with the decision, the member has a right to complain. The member has these rights, and based on those rights, if they do come back, if this complaint comes to us or at your level, and you as a leader is aware of this complaint, there should be some sort of resolution or a confirmation, basically, to give back to the member. But if within a matter of days, most complaints can be resolved. Like here, it says 10 days, but some can take a little bit longer, but it shouldn't take longer than 90 days. So that is where we're really trying to provide a little bit more education. We don't want members to be scared to talk to the case managers, if they feel like something is not right, I think I need more services. This is what has happened to me. If they don't agree with the decision, they have a right to speak up. They have a right to say something because this is their plan. So I think that's one of the things that really needs to be reiterated at the case manager level. Next slide. So what is a grievance? There's been questions about the grievance and appeal. An applicant or a member or an authorized representative can file a grievance. And a grievance, there's a couple of examples here. It could be just a general complaint. It could be, an environmental hazard in a doctor's office. We have those that can be resolved at the level. If you get one at your level, you can always send it over to Access and say, hey, you know what, this is what the member had mentioned, or you could do the outreach to the provider and find out what is going on. Or, you know, if you do see something, you can always submit that to the Access level for Access to also investigate and look into. This is one of the ones, the next one is kind of the ones that we get a lot of. Anytime there is a complaint by a member, this is what we hear: impoliteness or rudeness of a provider. It's not just necessarily a doctor or doctor's office or hospital personnel, it's the case managers too. You know, it's the supervisor, it's whoever works for the long-term care program. If they feel, because you are providing case management services to the member, and there could be reasons, you know, why a member is very upset, like I said before, but they, you know, if they feel that they've been, if someone who they're working with has been rude or they've been impolite, they can file a grievance also. They can file a complaint, they can file a grievance against whoever that they feel that they're working with that's supposed to be helping them with their plan. So it's not just to say they're right, you know, they just, you know, they're right, their complaint is valid. You know, we do go through that process of reviewing, looking at it, and we do at some points, we do provide that education at the Access level to say, look, this is the reason why, we have the documentation. We then sometimes have to ask for information from the case manager and say, okay, we have the information here. We see that it was appropriate. Supervisor reviewed it. We feel confident that your case manager did the appropriate, you know, job to ensure that the members receive the services that, you know, that was medically necessary. So we do look at all that information when we do receive these types of complaints. So let me see, I think I duplicated that. Impoliteness and rudeness of office staff. I guess that's where we also fall into play. Even at our level, like I said, we give out our information if someone feels that we have been, you know, if they say, well, you're not helping me, you're rude, you're not siding with us, you're siding with the case managers, you know, we do get that. And like I said, I always tell my team, you know, if there is nothing that they know and they're confident that they didn't do anything wrong, that there's documentation included in the conversation or the communication that they've had with a family member or member, then you know, they can give out their information or their supervisor's information. And based on what we hear, we always reiterate, well, we have this information. So anytime that we ask for information from a case manager is really just to assist the program, the health plan, to say, did you make the appropriate decision based on the complaint that we received, whether it was a phone call, email, you know, we follow back up with the health plan. We look at everything and then we follow up with the health plan and say, did you look at this? Did you look at this? This is what happened and this is what we're seeing. So we'll, you know, we at times we might have to ask for documentation that we need to review, especially when it actually becomes, they do actually submit a written complaint or a grievance, then by law, we have to look at it. We have no choice but to review everything. So this is what the grievance is. Next slide. And an appeal is a request from an applicant, member, provider, health plan, or other approved entity to consider or change a decision, also known as an action. And with these, you know, like if there is some sort of denial or termination of services or a request that the member has a right to appeal it. And of course, we go through the NOA process that has to be provided to the member. We have been checking some of these CA 165 screen. If there ever is a reduction of services, or if you see in the case file as you're auditing that something was denied or not followed through by the case manager, a request, a long-term care service that was requested by the member is documented, but there is no PA request or requests, at your level, or you don't see it on the CA 165. That's what the auditing is. That's why it's important to look at the case file and ensure that there is no denial or reduction or suspension or termination of services. If there is, the case manager really needs to inform the member why the services were reduced, why the services cannot be provided to the member. And they also have a right to know that they can file, an appeal to appeal the decision that was made by the case manager. So these are some things that, like I said, we have seen in some of these members' cases were valid. We looked at the system and we seen, yeah, they were getting, 600 hours or 600 units of services, and then all of a sudden they're down to 400. What happened? We look at the comments in the comment screen, and there is no comments in there. So what happened? And then we then asked the member, did you get a letter, or an email or any type of communication to let you know that these services were going to be reduced? Did you sign the assessment? Were you aware that they were going to reduce your services? And did you at that time not agree? Because if you did not agree, then you really do need to talk to your case manager. And some members say, I don't understand. They didn't explain it to me. They just told me that your services were going to be reduced. And we all know a lot of our elderly members, they don't understand English very well. These are our elderly population I'm talking about. They don't understand the services very well. They don't know really why some of these things happen. But then another family member observes and say, hey, what happened? Why did this happen to you? I don't know. And those are the family members that advocate for their family, the member themselves, and they contact Access and say, this is how it was, and this is what happened. I was never presented with, a way to appeal this decision. We don't agree with it. The member signed this. They had no idea what they were signing. Even at that point, case managers and supervisors really need to review the case to make sure that the appropriate decision was made and that there's documentation in the file to justify why they reduced the services, and they still need to present that in a way for them. If they stand by the decision that they made, they do need to provide that information in a way to the member so that that member can be heard at another level if they still disagree with the plan at the plan level. Next slide. Okay, so there's been a couple of things, I guess, lessons learned from all of this, even though these processes are in place already. It's outlined in the policies, it's outlined in the grievance and appeal website. There are certain processes that we're all owners of this. If there is at any time that a member, if you feel like, the member said this to me, you go to your supervisor, and you and your supervisor, or the case manager and the supervisor, discuss it and say, let's seek some guidance from Access. We're going to make this decision. Did we make an appropriate decision? You're always free to, supervisor and case manager can call one of the coordinators or the supervisor and talk it through. Did I make the appropriate decision? Because I think one of the person who has experience in going through, being present at the court, having to be able to advocate for their actions taken on a service. We have one internally, Cheryl, she had to present at one point in time. She was called in to actually provide the information that she had regarding a decision that the member did not agree with. So, for a complaint to be made, it can be made in person, it can be made by phone, or it can be in writing. However way that it comes to us, make sure that you, or to you guys, make sure the case manager acknowledges that they receive, the complaint, and make sure that, if the member does ask, I need you to respond to me in an email, or if they send an email respond to the member. And we do have at least, the members, you should acknowledge that whether it's over the phone right then and there or within 5 days. Make sure that the member knows that they've been heard and that you are doing something with that complaint. And usually, typically, when the complaint comes, it comes to the supervisor level. So just make sure that you acknowledge it. So then when the member does come to us and say, nobody's giving me a call back, nobody's addressing my complaint, at least you have documentation in the case file to say, you know what, I as a supervisor have reviewed the complaint that the member or representative had. I reviewed it and we're taking action on it. And we received this complaint on this day. We still have 2 more days to provide a response. Okay, then, because the member sometimes is on a rampage. They'll call you, call access and call everyone else complaining. It sometimes goes to our director level or tribal liaison level, and it comes from them. So more documentation as a leader. Make sure to these complaints, please make sure that you address them at your level, so that way when it does come to our level, we know that you have documentation. This is how you tried to resolve the issue at your level, but evidently it didn't work because they now jumped over and went straight to access. They even went over us and went straight to the director. So more documentation. The file does help your case manager, and it does help you as a leader to be able to provide that support to your case manager. So some of the complaints, even though we feel, well, that's nothing, why are they saying that? They, like I said, members have a right. If they feel that a provider or an employee does not return the phone calls, they have a right to file a complaint. If a provider or employee is rude, they have a right to file a complaint. Any type of services is not scheduled, or the provider is not, providing the services, they're not, like for transportation, if they're not arriving on time or they're always late, they have a right to file a complaint to access, or even to you. If the more complaints you get, you contact the provider and say, hey, this has been an ongoing issue. You have it documented. Driver was late again. I know there's been a couple of cases that we reviewed, and there was those cases where we said, oh, okay, they did follow up. Driver was continuously late, and we've already addressed this. Access, look, this is the member's complaint. It came to us. We've addressed it 4 or 5 times. They're still coming late. We want to let you know, because there's limited amount of transportation drivers out there. So we're letting you access know that this registered provider is not coming on time to pick up the member when they have like a dialysis appointment. They cannot miss those appointments. So that kind of information, like I said, anyone can file a complaint. You at your level on behalf of the member can also file the complaint if you see that this is an ongoing situation. And even problems with getting an appointment, if the member tells you, or we're not, they're not able to get us in. We've tried and tried again, and they're not getting us in for our appointment. Or a member can even say, which was recently, I haven't been reviewed. I'm brand new and I'm new to the program. I haven't seen my case manager. I don't know who my case manager is. Those kind of complaints can come to us, and it did come to us. So that is the reason why, I'm really trying to focus on this. Please, be mindful of your case managers, what they're doing, how they're doing, if there's any issues, because sometimes that's where you can see, is there burnout happening? Do I need to assist my case manager? How can I support my case manager? So you'll have more of the insight at your level, because when it comes to the access level, we have no choice but to immediately provide a response to that member and let that member know, if it's not going to be immediate, how long is it going to take? We have a responsibility to reply to that member. But sometimes it does take the teamwork from the tribal long-term care to say, so when we're asking for documents, it's not right away that we are siding with anyone. We always have to stay neutral. We have to make sure that we hear both sides and review everything that we receive, and then provide some guidance at the tribal level to say, this is what you need to do. This is what you probably need to look at. Maybe you need to do the review again with the case manager. We'll recommend certain things, but it's really up to your discretion how you're going to handle these cases. So, and if it continues to, get higher, it then could go to, if it interferes with the quality of care, then that's another level of, it's no longer a complaint because now it's affecting the member's quality of care. Next slide. So that's when it gets to this level, reporting the quality of care about, if a member has, a concern with their care and the services, or they're not getting the services. With this one particular member that I had mentioned earlier, the member had not received services for a long time. I mean, we looked at the reports, we looked at the CA-165 screen. We have seen that the member has not received services at all. But there was a review. There was a review date on there. So that's when we started looking at it and said, hey, wait a minute, what's going on here? So the member's complaint was valid. And during that period, once the member enrolls on with your plan, once the member is assigned to your plan, your case managers and you as a program are responsible for that member. So in the event that, if a member fell and there was no services for that member even have been established, it could turn into a quality of care issue. It could result in something fatal. For that reason, it's really, really important that case managers follow through with the timelines that are outlined in our policies, making sure that they try to stay within the timelines, especially for those members that have high needs. If they need more one-to-one assistance, if they're wandering, in the summer it's hot in southern Arizona. In the winter, it's freezing cold up north, So those are some factors you really have to put into play, and working with your case manager to schedule these reviews so there's no delay in reviews, there's no delay in services. Putting a dummy code as a provider is not appropriate. If you knew that case manager, that member needed a specific service, you need to make sure that those services continue without any gaps in services. Not because you were not able to review the member. You should never use the dummy code unless you are very, very certain that there is informal support in the home for that particular member. So looking at it from that standpoint, you want to make sure that your case manager is abiding by what they need to in order to coordinate those services for the member. So we don't want it to result into a quality of care. So, but these are some of the ways that a member, if they feel that it has resulted in the quality of care by the provider, the person who provides the healthcare services to the member. We received, sometimes information from the provider saying we were only authorized, 4 units a day, but we know the member needs more services. And then that's when we always tell the healthcare provider, that the member or the member's representative really needs to, contact their case manager and have the case manager reassess, especially if the member had surgery or if the member was coming out from an inpatient stay, being, sent home, making sure that service is available. If there needs to be any increase in services, make sure those are all coordinated for the member to avoid any type of quality of care concerns. And of course, we all have case managers, also members, or they can always provide that information to QOC to inform them that, this is what's happening to me. I'm not able to receive these services, or my family member, I'm concerned about the type of services that my member has right now. Any issues related to healthcare or health plans that are not timely access to services, which means the CA-165 if those service lines are not completed according to the member to avoid any gaps in services, they can submit that because that's a quality of care concern. The case manager is responsible, the health plan is responsible for coordinating that care that that member needs according to the assessment. And it will not be determined until that assessment has been done. So it's really important to, when you get that inpatient notification, that the case manager is on it, making sure that coordination of care happens after discharge and be involved in that discharge planning. It's really, really important to make sure, and document everything. So that way you know that your case manager did what they needed to do. You as a supervisor provided that support to your case manager. So it doesn't result in a quality of care and it doesn't result at the level where it needs to be communicated to your long-term care program leadership. Next slide. Okay, on to other things. Policy updates and unwinding for the PHE. So there have been updates in the policy, and the policies listed here. And those policies are basically to comply with the ALTCS setting rules, or it's just a revised standard review, the 5-year review of some of these policies. If there really hasn't been any changes or updates and edits that have been made within the last 5 years, the policy team usually pulls those files and policies and actually go in to do some editing. But these policies will be effective. There's been very, very minor changes, and most of it was related to comply with the ALTCS setting rules. And they will be effective 10/1/22, and some of them are in regards to the face-to-face, the PCP, the person-centered planning tool, the the updates for that. All of that is have been revised. So you'll get notification. There will be a breakdown that I'll provide, more or less like a flyer to the case managers in the event that you want to look at it at a supervisor level. You can do that, what type of edits were made, but mainly most of it were because of the ALTCS setting rules. So next slide. I think this is my last slide. I better have some coffee here. Next slide. There's been a lot of discussion regarding the long-term care flexibilities and the conversations that we've been having internally regarding those flexibilities. I did provide a link here for all of you as leaders, and these are just some things that I've pulled from that that document. But it does outline, you know, at the end of the public health emergency, that quarter that it's going to end is basically when all these flexibilities will be lifted. So such as, you know, the removal of the hourly service limits to 40 hours for spouses. I do know that for the children ones, where the parents were providing that support for their children, that was an exception that was made. That looks like it's going to continue. But that all of that information is in this link. Is actually like a provider, like it's like a manual. So if you go in there, you'll see all the different actions that Access has taken for the unwinding of this flexibility. So these are some of the things that was mentioned. Even though I know that many of you are out there. Your case managers are out doing the face-to-face reviews now. That once that ends, it's really basically going to be, you have to go back out there and start doing these reviews, doing these in person. There are exceptions that were made. It does really outline when these exceptions are, like I said, the flexibilities will end. The electronic sign-off, I believe that's what I'm going to lead into, but the sign-offs also, I know that some of you all have just been doing the review over the phone, sending the member their documentation that they need based on the review and the services that they were going to get, and you would wait to obtain that signature, or else some of the plans were allowing for the electronic signature sign off. But more and more, you know, once this flexibility has ended, then the face-to-face, the member has to sign off on the information that the service plans that they have to ensure, or the person-centered planning, I should say, that they have in place that you all discuss to make sure that everyone is in agreement with what has been assessed. Next slide. So we've talked about this quite a bit. I think the reason why we really wanted to bring this up is my team is going to go into this, dive deeper into this in their presentations, but there has been some discussion revolving around informal support. You know, is the informal support, have they been identified? Did they agree? Did the member agree? You know, making sure that we receive member signatures, making sure that we're allowing that member to, by doing that, you're allowing that member to engage and participate in their assessment. They understand the process that is happening, that even if they don't, there is a family member that is able to interpret or provide that support to the member to let them know that they understand. I know there are some members that could be challenging, that, you know, you have to explain things over and over again to them. You know, that's where, you know, as a leader, who to pair your members up with to ensure that they try to get as much benefit from the program that we have, all the services under long-term care, making sure and ensuring that, you know, members' rights are being practiced. And part of that is making sure that the signatures are received. And just because, you know, their son is living in the home, their adult child is living in the home, or other family members are in the home, the case manager should not be taking that into consideration. Because you live here, you have to do it. You know, we at the access level do not know the family dynamics in the home. The case manager probably has a better relationship with the members at that level. At the member level, they're able to know, you know, who's there, who provides services, what is really actually informal support. You know, is this informal support available to do the service? Are they willing to provide that informal support? You know, in the past, we've heard, you know, well, they're living in the home, they should take care of the member. We all know there are some family members that don't get along. Even though they live in the home, they don't get along. So that's where we really, case managers really have to be mindful and not assume that someone is living in the home, they're going to provide that you know, informal support. And that's where the signatures are really, really important. Making sure that, you know, whoever is identified as the informal support does acknowledge it. There is updates in the policy that where the informal support does have to sign off and saying, yes, they're willing to do that, because you don't want to run into the risk that informal support is not available. But signatures is required, making sure that you have a copy of the member's signature. Making sure you're not using, you know, like rubber stamps or copying and pasting the signatures. Even the case manager should not be doing that also, because that really, you know, it really does create that, is it just copying and pasting? And if these are become legal documents, if they were appealed, it becomes a legal document. So just to ensure and remind your case managers that signature requirements, you know, they need to make sure that they get the signature of those members. So, and there are other information and resources related to signatures, which we've included here on this slide. Next slide. And that concludes my presentation. Thank you. I hope I didn't put anybody to sleep so early. Hopefully everybody will wake up with this icebreaker. Thank you so much, everyone. Or I should say, or should I say, are there any questions? I didn't even leave it open for questions.
Wake up, everybody. Just kidding. I'm sure there will be after they, you know, review stuff, but thank you.
Thank you. Thank you, Rachel. I think there was a question.
Oh, was there? Okay.
Yeah, in the chat.
Is there any updates on EVV? Okay, Ernestine, specifically, what are you talking? Oh, you know what? What are you talking about, first of all? Is it a provider question or on the case manager side? Can you unmute yourself or maybe type in, or maybe I can just give a level of updates. Okay.
Rachel, I just wanted to go over EVV and see where we were at as far as having all of our home care agencies. If I'm just concerned about 2 agencies that we are working with
Mhm.
who I don't believe are compliant with EVV, and I do know that the hard edits are coming out on November.
Yes.
Kind of what's going on. Should they not be ready by then? I mean, would our members need to transfer to a different home care agency?
Yes, that is one of the things, the communication that will be going out. Access is drafting that email on the fee for service side. We are drafting an email to these providers to let them know, hey, you have not you are not in compliance with the EVV. At that time, we'll communicate that back to you. But Ernestine, if you could send me over the names of the provider and their ID, I can follow up with the Sendata team to make sure that are they in compliance? Have they completed the training? And I'll provide that response back to you just to reassure you that where they're at on complying. If they're not in, if they haven't started, or if they need support or guidance, then we at the access level would need to provide that support to them.
Thank you, Rachel.
You're welcome.
Are there any more questions? Okay, we're a little bit ahead of time, but we're going to go ahead and start our icebreaker. So Bandana and I worked very hard on this, and it's a breeze. So crack your knuckles, squeeze your stress ball a few, because it's going to depend on how fast you type. Okay. So next slide, Charlie, please. And the ones that are participating are only our external participants, which are all the case manager supervisors and their lead case managers and their case managers. So access, we are sitting back and sipping on our coffee. So our icebreaker is called Guess the Place. We will show you a picture of a location in the state of Arizona, and whoever types in the answer first, we will keep track. It's real brief, but you got to be fast, okay? Because we're going to switch the slide as soon as we get the answer. Okay, go. Where is this beautiful picture? Next slide. Awesome. Of course, we can't miss that. One of the seven wonders of the world, of the Southwest. Okay, ready, set, go. Quick, quick, quick, quick, quick. Can anybody else be more specific on the name of the actual place besides the location? Okay.
Lakeisha said Holy
We got one.
Cross.
Yes, we got that. Okay, thank you, Sonny. Okay. Answer? That is correct. It's in Sedona, Arizona, the Chapel of the Holy Cross. Next slide. Ready? Go. Oh gosh, where could this be?
Bonnie answered it.
Okay, awesome. Answer, please. City of Phoenix. Woohoo. All righty. Ready, set, go. Come on, come on. All right, Sonia, yes, Fountain Hills. It's the fountain at Fountain Hills. Answer? Fountain Hills. And a little trivia, once in the tallest, one of the tallest in the world, and it stands up to 560 feet, which is calculated to 170. And I know seen it during St. Patty's Day, and they color it green. So that's pretty cool. Thank you. Next slide. Ready, set, go. Ooh, where is this at? Come on, come on. Come on. All right, come on, keep going. It's actually, it has a specific name. I don't see it in the chat yet, except for an Access employee.
And we don't get to participate.
Lakeisha
All
answered the
right,
question.
okay. Way to
Lakeisha
go,
answered the question.
Lakeisha. Woohoo! Yes, the answer is Picacho Peak, off the west side of the I-10 heading south to Tucson. So Raydell and Sonia, you guys were close. Picacho Peak. Okay, next slide. We are going to go. Everybody should have this. All right, way to go, Raydell. Raydell got that. Of course, that is Hoover Dam. Sonny,
Lakeisha, yeah, Raydell got it.
Sonny, would you tell the little tidbit you told us earlier?
Oh, yes. There was an explosion at Hoover Dam just recently. I don't know if everybody saw that on the news, but something exploded. So
Yeah. Can you imagine
pretty big explosion?
being on that bridge or crossing it and you feel the movement? Yikes.
Yeah.
Anyway, thank you, Sonny. So the answer was Hoover Dam. All right. Next slide. Thank you. Thank you, all of you, for participating in our icebreaker, and we will come up and with the results. And as before at our quarterly meeting, we will be sending out a gift card. So we appreciate your participation, and we hope you had fun with that. Thank you.
Thank you very much, ladies. That was very fun. Okay, this is Sonny Fisher, and we are going to go over the policy definitions details. I know that Rachel did talk about this briefly already, that there's policies that have changed, and this is specifically to do with the policy definitions. So I'm not going to go over in depth every screen because there's a lot of them. Every slide, I should say, but it will be included when it gets uploaded to the digital toolbox, is you will have access to that. And so next slide. Okay, so the Access has made the changes to the policies to remove definitions from the actual individual policies, and they've all been compiled in one place in the AMPM policy, and it is a resource. You find it under resources, and it is actually called Contract and Policy Dictionary. And I've provided the link, although we're not going to click on it right now. Okay, next slide. And although not an exhaustive list, I've just pulled out some of the most common definitions that apply directly to the tribal ALTCS on the following pages. And you should be going in and looking at these yourself with your teams, making sure that you guys are kind of familiar with this. It's not, you know, highly critical that you do this, you know, as soon as you get back, but it's something that you need to look at some point. So on page 3, it talks about acute care only, and it describes that. So I'm not going to go into detail because you guys can read that yourself because I've got a lot of screens. Go ahead, next. And on page 5 is the advanced care planning definition. Go ahead, next slide. Page 7, it talks about access fee for service, which is where we happen to work here at Tribal ALTCS. We're in the fee-for-service program. And then on page 7, it talks about the medical policy manual, the AMPM. So that is just some brief things. Next slide. Page 9, there's some information on the access registered provider, alternative, home and community-based settings, so the HCBS settings. Next slide. This is an ongoing of the HCBS, talking about the different placements and all of that. So next slide. Page 12 talks about the Arizona Long-Term Care System, which is an access program. It goes on and describes a little more detail than when we talk about. This is really helpful for those of you who have new staff. Maybe they need to hear this kind of stuff. Is, you know, what does it mean when you say the Arizona Long-Term Care Services ALTCS local office? And you know, these are just some things that can help you. So next. Also on page 12, it talks about the transitional program, the ALTCS transitional program, which you see coming from the coordinators on a monthly basis, those reports. And then on page 13, it talks about assisted living center. Next slide. Page 13 also has the assisted living facility description, definition, the listed assisted living home, the authorized representative. Next slide. On page 15, it talks about what a bed hold is, and also talks about the behavioral health disorder, what that meaning, what that definition means. Next slide. Page 16 does talk about the behavioral health facility, and goes on to describe a little more detail about that. And so that you could find there what qualifies, etc. So next slide. Also on page 16 is the BERF, the Behavioral Health Inpatient Facilities, or BHIF, excuse me, BHIF, and which is a healthcare institution. And then it talks about the BERF on page 17, the Behavioral Health Residential Facility. Next slide. Page 17 also talks, oh, maybe I just went over that. I may have duplicated that. Page 19 talks about what a caregiver is, case management, what that is. Next slide. Page 19 and 20 talks about the case manager, what that description is, Centers for Disease Control and Prevention. You hear us talking about CDC. If you needed to know what that was, this is a little better description of it. And the CMS, if you needed to know what that is, there's a little more detail about that. Next slide. Page 23 is talking about the clinical record, and it says to refer to the medical record. So I provided that information right there. It's on page 65 of the medical record. So if somebody says we need to see the medical records and you're not sure what that is, you can look at that definition. Page 34 does talk about the direct care services. Okay, next slide. Page 34 does talk about, and 36 talks about the direct care worker, that description, and the fee for service, provider, a healthcare decision maker. Again, more descriptions, more detailed descriptions. Next slide. Page 41 and 42 and 47. Oh, next slide. I must have duplicated that. Okay. Page 49 and 50 and 53 has the The actual HCBS talks about what that is. Well, it just basically spells it out. And then the home delivered meals, you guys know what that is, but you know, if you have new case managers, this might be really helpful for them. Page 53, the informal support. What is that? What do they do? Next slide. Page 54 talks about the institutional settings, what that setting is, the different placements, and HCBS settings, which could be an alternative HCBS setting. Next slide. Page 55 and then 66 talks about the intergovernmental agreement, which most of you, all but one of the programs, has an IGA in place, and they're all signed yet. And page 66 does talk about medical supplies. If somebody wanted to know what that means, you can look it up here. We have the description of Medicare. It is a federal program. Next slide. The description of a member, generic to access. Page 73, the notice of adverse action determination, and what that means. Next slide. Page 74 talks about the nursing facilities and what those are, and a little more description there. You can look at it. Next slide. Page 79 and 82 talks about the person-centered, being person-centered. What does that mean? And we've gone over that in depth, and when those of you who went through that person-centered service plan training, you know this, but maybe your new staff don't know it so well. This would be good for them. And then the PCSP, what is that? If somebody asks you, a new case manager says, what does PCSP mean? You can go right here and take it to them and show it. Page 82 also has a prepaid medical management information system, which is the system we use, PMMIS, talks about what that is. Okay, next. Page 83, 88, and 89 talks about prior authorization. What is that? Quality of care concern. We talk about that a lot. Sometimes you'll hear us talk about the QOC. Here's the description of that, the definition, and reduction of service. I know Rachel even briefly touched on that this morning about reduction in services. So here is a little more detail on that. Next slide. Page 93 and 96 talks about room and board and what that means, what that description definition is, serious mental illness, and the service plan. So again, for new case managers, this would be great for them to go in and read these and kind of get familiar with these terms. Next slide. Page 96, 104, and 106 and 107 talks about the share of cost. What is that? Third-party liability. You'll hear us talk about that occasionally. Transportation, NEMT, you guys deal with that every day. What is that definition? And the treatment plan. What is that definition? Next slide. Page 107, 109, and 111 again. The first one talks about tribal ALTCS, the actual tribal ALTCS fee-for-service program, which you are all a part of. And the uniform assessment tool, which you all use every day. And what does that exactly mean? If you needed to know, there it is. And then page 111 talks about the whole person care. And that's what we're all about, is trying to make sure that we cover the whole person. So next slide. And that's everything that I extracted. There's so much more, but I just pulled out a little bit for you guys. So are there any questions?
Thank you, Sonny.
Okay, thank
If
you.
you have any questions, go ahead and send them to Sonny, and then we can go ahead and look at them. Whatever tribe it's coming from, is it okay, Sonny, if they copy us coordinators too, so we can kind of-
Absolutely.
Okay.
Absolutely. Yes.
So with your questions, go ahead and email your questions to Sonny, and then copy whichever coordinator is assigned to your tribal program. That way we can all learn together, keep learning together.
Yes, that's
Thank
right.
you, everyone.
Okay, we're going to have a 10-minute break here. So this is the time to get up and go stretch your legs, go to the restroom, get your coffee, whatever you need. And we'll come back at
10:30.
should we say 10:30? That'll give you 12 minutes. We're going to give you 2 extra minutes there. At 10:30, come back, make sure you're ready to go because we've got a full packed schedule. And I'm going to be signing off now because I do have a funeral to attend. So I will talk to you all later, and God bless. Thank you all for everything that you guys do.
Bye, Sunny.
Bye.
Thank you, Sonny.
Thank you.
Okay, everybody get up and stretch, get your coffee, refill. Thank you. Okay, everybody, did everybody get their drinks, their snacks? We got a few more topics to go, and we want to get started again.
Okay, welcome back, everybody. So we have our next presenter here, Bendina.
Good morning, everyone.
Good morning.
We'll be reviewing the prior authorization request that is coming into access. Next slide, please. From January 1st to Monday of this week, we received 2,525 PA requests from all the tribes. 356 requests were duplicate. 329 requests are missing information. 7 requests were multiple members. 109 requests were no PA required. These PAs does not need access authorization because you can approve it. This way, the members are not waiting to receive services. Our team has authorized 1,577 PA requests. 75 requests were PA under review. 57 requests were pending PA. 15 requests are blank. Next slide, please. This is more detail of the grand total of 2,525. This report is from all the offices, so if you want to know where your office falls in, please contact your assigned coordinator to get the report for your individual office. And you can work with your case managers to improve on this. Case managers did submit the packet with all the required documentation to approve. As you can see that we have authorized and approved 1,577 PA requests. Thank you. Next slide, please. Any questions?
I have one. This is Annie.
Okay.
How do we know when they're pending? Do you guys send us something telling us, okay,
Yes,
yours is pending?
we always update on CA 165 screen.
Okay,
Our status, yes.
thank
Does
you.
that include notifications for open line completions?
No, that doesn't. Some of the tribes are real successful where they hardly have any open line requests. So that would be the case manager's responsibility to ensure and check the open lines that they have submitted. We are trying very hard, and our new case management specialist, Charlie, has been really working hard to ensure that they get completed within or we start looking at them reviewing within the 72-hour time frame. So our goal is to not let it get to over the 72-hour. Some of the issues, again, may be just errors in the documentation, marking the wrong choice on the cover sheet. That happened this past week with, I believe it was 2 or 3 requests. They were marked open line request, but it was an out-of-state placement. So it goes in automatically to the out-of-state placement form. It doesn't come to the open line request. Another one was a DME, was marked DME, but then it was an open line request. So just be really careful when you're filling those out. I know we try to get those things done. You guys are using the previous one that you've downloaded, and maybe you just forget to change the selection of what type of document you're sending in. Thank you.
Okay, our next presenter will be Cheryl, if we don't have any more questions.
Thank you, Charlie.
You're welcome.
So, thank you. Okay, you guys. So I'm going to be talking about the DFSM, the D-130 voluntary withdrawal form. That is the official name of the access form for the member to sign and date at the time of their choosing to be withdrawn from the ALTCS benefits program. The other topic is going to be policy 1620-17 out of the AMPM policy, and those are changes regarding informal supports. Next slide. So one of the, as a case manager, as even for access staff, looking at the forms or the requests coming from members, we also have to clarify the process for the members' requests. And pertaining to voluntary withdrawals, cases are discontinued for voluntary withdrawal. Some of them may take longer than the standard timeframes. And this can be caused when on the voluntary withdrawal form, there's the case manager manually enters two choices, either the one for voluntary withdrawal or maybe the member moved out of state. So if those two reasons are checked, then that's when a delay can happen, because when it goes to our eligibility system, which is HIA Plus, it will apply the adverse action rule for the other reason, which means it's gonna do it for the moved out of state reason instead. And this is the reason why it can delay the discontinuance and cause an eligibility error. The issue may cause a delay in customer assessing if they indeed were moving to a new state. Then the state that they're moving to will require confirmation that the Arizona ALTCS benefits ended before they can approve the new state residency for ALTCS benefits. So be very careful in looking at the form and only marking one choice. Next slide. So continue clarification of the withdrawal. We're going to continue. This is an example, kind of already went into it. The customer called the ALTCS access eligibility to withdraw immediately because he moved to, it could be Utah, New Mexico, or Colorado, because there we are in the four corners. And this member wants to apply for benefits in the new state state of residency. If the worker, which means the tribal case manager, selects the voluntary withdrawal and for immediate residency reasons, HIA will follow the adverse action rules for the residency, and medical assistance will not end until November 1st. So they always give a 30-day or more leeway just to ensure that everything is in place when it comes to updating the new eligibility requirements. So again, the tribal case manager must select only the voluntary withdrawal reason for the customer, and this should be processed more timely than if you did two. Next slide. This one is going to be really important because we're seeing a lot of members who are requesting to withdraw from their ALTCS benefits. And we're still not seeing a lot of detailed reasons for this, but what we need to do as the tribal ALTCS plan, and also we as access, is we need to consider again the CMS initiative, person-centered service planning. We have to concentrate on that because it's a CMS rule for members who have qualified financially and medically to be able to tap into these benefits when they're in the home community base areas. The next thing we want to look at really look at is their physical disabilities and their chronic health conditions, which means you're going to have to assess and know currently what is going on with the member medically and with their chronic health conditions. Because remember, they're not, chronic means ongoing. Most of the majority of our members are not going to get better. They're not going to go back, and they're not going to be able to get up out of that wheelchair and start running again. We got to consider that. And when we have to consider that, we have to consider it because of the benefits they're eligible for, which is ALTCS. ALTCS means they're eligible for the HCBS services and CMS, including CMS, and that also includes Arizona State Medicaid. So that could mean AIHP, that could mean kids care. Everything is under that umbrella. So it's very, very important. Case managers need to consider all these areas before you go with what the member is requesting. The next important consideration is informed choice. So with informed choice, what you want to ask yourself is, what does the member want? Yes, every member, as Rachel stated prior, every member has their rights. We don't want to take away those rights. And then a lot of you, I know you're going to say, well, it's their right. It's their choice to do this. Yes, it is. It really is. We're not saying they don't have a right to voluntary withdrawal, but as the assigned case manager, we need to look at these, consider all these things before we say, okay, you know, I'll help you process this. So what you want to know is, what does the person want? What is possible for the person? And does the person understand the risks and trade-offs of their decision? So with all that, then you give them informed consent. You're doing your job, you're doing your due diligence and letting them know all these things. Oh, you know, we don't want to say, well, you have diabetes. You're gonna, you know, you're gonna say, Cheryl, well, you know, considering you have diabetes, yes, it's well managed. Yes, I see that, you know, you're on insulin, you're taking all these meds, you know, I just want you to know that I want to make sure you understand getting off this program, what the risk could be for your continued well-being. So that's all informed consent. That's a conversation that we really, really need to get skilled on. We really need to initiate with our members, because all this is centered around the person, not us as the case managers, not us as access staff. We're not trying to fix them. We're trying to help them be have the best quality of life, and make sure that they're not defeated if they make a choice and then it doesn't work. We want to encourage them and let them know that we're here. One of the main challenges that can be, if they voluntarily withdraw, then, and all that whole process goes through, and they end up in the hospital for a wound or a fracture, then this whole process of applying for ALTCS is going to start all over again. So that needs to be also have them informed about, is the process of reapplying is going to be another challenge. So lastly, of course, self-determination, and which means that is being in control of your life, their control of their life. We want them to feel that way. We don't want them to think that we are controlling them. Oh no, you can't get those services. Oh no, you can't withdraw. They can do whatever they want, but we have the job to make sure that they understand all the options, what the outcomes could be, the potential risks, and the consequences of their decision. And that's really going to take a lot of due diligence on all of us's part to document this. Document. And if that's all, all that has been done and they're still say, well, I do want to withdraw. Okay, next slide. Next slide. So then that would be the process of, so, okay, this is what we have to do. This is the form for the voluntary withdrawal. I know there's some of them that I've seen are still using the old form. This here is the updated form for the voluntary withdrawal. And I did put on there, I probably will go ahead and put it on the, attach it to our slides. So there's a phone number right there. The member, if they got that level of understanding where they can do it themselves. We had a young gentleman recently last week that actually got a job and he's getting some health benefits through his employer. So that's awesome. That's a success story for him. He was able to go ahead and call the local ALTCS office, the numbers they're provided, and then it's on the form also. It's the 855 HIA Plus, which is 855-432-7587. He was able to call in and speak to the eligibility worker and say, I want to discontinue, I want a voluntary withdrawal because I got a job, I'm working full time, and they pay my health benefits. Just with that call, they started the process to voluntary withdraw him. He didn't wait because, again, that's another big key point of education is letting your members know, especially if they're not able to advocate for themselves, someone needs to know and understand that that needs to be done for them. This one was quite easy. He did it himself. If I see a disenrollment on the roster, I go in and I start looking. That's what we do as coordinators also. Plus and say, and that's how I saw the note that the member called in himself. Then the case manager also sent in the withdrawal form, and the member did sign and date it. So that was a really smooth process that went through. So just be really careful when you're filling out the form. Fill out as much information as you can. I see a lot of them come in blank, the boxes here, the 4 or 5 boxes in the middle of the form, they'll be blank, but down here they'll have the little statement, that the voluntary withdrawal statement. Go ahead and please fill out as much as you can, and that way it helps the eligibility workers. They don't know rural Indian country, so they're like, what does this all mean? Why are they withdrawing? What are we, how are we going to mark this? Because like I said, if there's if there's more than one choice on there, then they don't know which way to process it. And that can just take up more time. So next slide. So now is the informal support policy. This is an AMPM policy 1620-7, and this has to do with the home and community-based services needs tool guideline. It's actually the H&T, the 4-page H&T. So it was recently updated last year in June 1st, 2021. And there's 2 sections that the case managers need to specifically pay attention to. The links right there. Next slide. And I know this is probably a review for most of you because you guys have been using it for quite a while. Now the policy states that whenever there's a member that's going to be getting informal support, page 1 of that H&T must be completed. It must have the name and the relationship who will be performing the informal supports for the member. It can't just say sister. That's it. It should have sister, comma, Cheryl Begay. Will be working with the member from 8 to 4:30 in the Monday through Friday. And then Cheryl Begay has to go back home to her own home and then the other sister comes in for the rest of the night. It has to be more specific and detailed like that now. And if the primary caregiver, Cheryl Begay, Monday through Friday, is going to be out for any reason during the assessed time that the member and the family informed the case manager about, it needs to be documented. So there's going to be a lot more checks and balances on informal supports, because we have a lot. We have a lot of members throughout our 2,500 plus population that are the dummy code is being used. So just to let you know, I'm on a project now, so you'll be hearing from me and I will be asking specifics. It'll be easier if those specifics are already documented on CA 165 in the comments, and I can go from there. But we are looking into that, and we are going to see. This could be a deficiency when it comes to auditing because of the person-centered service planning. Again, it centers around the member. No matter if they're getting informal support or they're getting 42 hours of paid caregiver service, everybody we're going to be assessing each and every member according to person-centered service planning. Okay, next slide. And here is the area that I'm talking about. You guys are familiar with this, where it's highlighted and it asks for the name and the relationship of the person who is going to be performing the informal supports. Just be specific there now and make sure that you have that name and relationship of the member. And if they're living in the home or not, that could also be identified on the CA 165 with a modifier as to if the caregiver is if the informal support is in the home or family living outside the home. Next slide. And then here's also important. Some have come across, I've seen, where the signatures are not completed on the last page of the H&T. There's that box now that has, I have contacted the informal support named above at the top of page 1, and she voluntarily agrees to provide the services indicated with no compensation. So that's very important. That's going to actually be a really good, that's us doing our due diligence, because we do not want this member who chose to have informal support with the agreement of the specific family member, they leave one day and for whatever reason, the member falls or something happens to the member, then the family can't come back to the case manager, they can't come back to the tribal program, or they can't come back to Access and say, no, I never agreed to do informal support. You know, I have a life, I had to leave, I had an emergency, whatever it may be. No matter if there's informal support in place, you also still have to think of a contingency plan, because that's huge in person-centered planning, also to reduce any risk of any further complications and adverse outcomes when it comes to the member's care. So this is going to be important to make sure that they know that what they're signing, that they agree to. Next slide. And again, this is what an example that was put in there. I told the case manager that I have a job outside of the home. Show me where it stated that I would take full responsibility of my family member. And that's what we've heard a lot of times. You know, some of them say they verbalize prior to this new policy, they verbalize, I'm going to do it. My mom took care of me all my life now. I'm going to do my part and take care of her. I don't want to get paid. So they say that, but now we need to ensure that we're doing our due diligence to make sure that it doesn't turn into an adverse action down the road if something should happen while the member's alone, because they could contest it in court. And if the case manager does not have this verbiage marked on the H&T, then the managed risk agreement should be in place to protect the case manager, the program, and access as an agency. Next slide. Are there any questions? Does it all make sense? Is it clear as mud?
There's a question in the chat.
Okay, can you read that to me, please? Hi, Cheryl. The question is, does the H&T need to be completed for those individuals with IFS only? The H&T tool states that it should be completed for those who request attendant care, personal care, and homemaking. Yes, it should be completed, because what the case manager is doing is they're going out and assessing, because the member has fit the criteria for HCBS, ALTCS HCBS services, which includes caregiver services. So when the case manager is out there doing their assessment, and they're seeing right in front of them how the member is moving, how the home environment is, the member's cognitive ability, you know, talking to them, their level of understanding. If for any reason the case manager assess in their scope of work that this member they do need services, okay, you still have to do the H&T, because in your scope of work, you're the assigned case manager. This is one of your responsibilities. You have to put that, use the guideline, that tool for guidelines as to what if all of a sudden the informal support was not there and you had to get a paid caregiver in there. It's going to make more sense to already have that in place as to what the case manager within their scope of work has assessed that the member needs, than to not have it there. So go ahead and complete it. And that's where, on that last page, is where you're going to discuss with the family that they have agreed that they are going to perform all the ADLs as informal supports at the current time. Does that answer your question, Lakeisha? Okay, yes, she did. Anybody else have any other questions? So another important reminder is, with all this, the informal supports, the voluntary withdrawal requests, consider the managed risk agreement. Now, if I went in there and I said, I want a voluntary withdrawal because, you know, I'm up and about, you know, I have a prosthesis. I know I'm a bilateral amputee. I have prosthesis. I'm getting around in the community. I go out and have a good time every now and then. My wheelchair got stolen one time when I was out, but I want to withdraw from the program. So you're looking at me and you're like, okay, you know, Cheryl, I know that you're in a wheelchair. You have these prosthesis. You know, is it really going to be wise for you to withdraw? You're going to look at it like that. You know, you're not just, I wouldn't be a good case manager if I just said, oh, okay, here's the form. No, that's not what we're doing, because we, as a state agency, and I'm sure as you guys, your tribal programs who have agreed to enter into the IGA as partners, so that your specific tribal members will get the services that are available to them. That's not a mission statement for any of us, is to just say, oh, okay, no, we need to perform our case management duties according to what person-centered service planning is, and to try to work with the member, communicate with the member to say, you know, I'm not sure that this is a good idea, but let me just let you know my reasons and then we'll go from there. So if you continue to feel like that you don't feel in your scope of work as a case manager that this is a good idea for them to voluntarily withdraw, then you start opening that conversation to say, okay, you know, for us to really truly understand each other, I need to do a managed risk agreement. And that's just saying that I've explained all the things that, you know, that you need to know about your decision. And it's just going to be put in your case file. They can refuse to do it, but at least, again, you did your due diligence to ensure that the member has that informed education from you. So manage risk agreement, using the dummy code, signatures for informal support, and those important considerations regarding changes in services. If anybody doesn't have any questions, I just want to thank you guys for all tuning in, and everybody have a great day.
All right, thank you so much, Cheryl. So our next presenter will be Vanessa, our tribal ALTCS nurse.
Hi, everybody. So going over Bandana's previous slides on the prior authorization requests coming in, I am going to be going over the common missing information, DME documentation, orthotic requirements, PA correction forms, and return faxes, as though those were the highest scoring items on the PA numbers that we received back. So for my next slide, I'm just going to go over the common missing information. A lot of common missing information that we do receive. The provider ID numbers are not included. Some of the requests come in with the fax cover sheets with the wrong member ID number. I have received initial PA requests where the script, face-to-face clinical notes from the providers to support medical necessity aren't included. Some of the requests have expired scripts, so I would need a new RX. Some requests have scripts, but there are no valid signatures. If the provider is submitting with an electronic signature, they do need the date stamp included with their electronic signature, or some of them don't have like their NPI number or the name isn't legible. If you have any questions regarding valid signatures, that is listed in policy 940 in the AMP. Some requests come in with increased supply requests, but there are no updated clinical. So I do need to see what change the member has had to require the increase in supplies that are being requested. For any PA corrections, I do need the PA correction form. I do see this a lot with wheelchairs where the provider wants dates of services changed. But I would need the PA correction form to go back in and make those changes to the dates of services. Next slide. I did include the AMPM policy that goes over what's required with the scripts that is listed in 310P, 810, 820, and 1620F. So the prescription or order with the ordering provider's name and dated signature with credentials listed, diagnosis indicated by ordering provider, description of medical condition, necessitating the supplies, equipment, and medical justification for supplies, equipment with anticipated outcome. Clinical documentation, including documentation that meets face-to-face encounter requirements, description of supplies, equipment requested, duration of use of equipment. item price plus any additional costs expected, costs if rented, provider identification number, and home evaluation when requested by DFSM. Next slide. I have received some orthotic prosthetic devices. For orthotics, orthosises, they're referred to the devices used to correct or enhance the use of part of your body. Orthotic devices provide comfort and support to the limb. Prosthetics, a device is an artificial limb to replace a limb on a person's body. Next slide. For the orthotic devices listed in policy 430, orthotics are covered by access members under the age of 21. It is listed in 430. Next slide. For orthotics for members who are above the age of 21, they do need to meet these criterias when the requests come in. The use of the orthotic is medically necessary as the preferred treatment option consistent with Medicare guidelines. The orthotic is less expensive than all other treatment options or surgical procedures to treat the same diagnosed condition. And the orthotic is ordered by a physician or PCP. Next slide. There is the statement, the orthotic is less expensive than all other treatment options or surgical procedures to treat the same diagnosed condition statement that is required for members who are over the age of 21. Most of the providers have their own script or their own form that has all of those criteria listed. So sometimes I'll send back, requesting this statement. This is just an example of one of the forms that we get, but again, the other providers have their own that have it listed. So they do know what we're requesting when it is being requested. Next slide. For maintenance and repairs of component parts is covered for orthotics and prosthetic devices. Reasonable repairs or adjustments of purchased orthotics and prosthetics are covered for all members to make the device serviceable, or when the repair cost is less than purchasing another unit. Components will be replaced when documentation is provided at the time authorization is sought to establish a component is not operating effectively. Next slide. Prior authorization correction forms. When is a PA correction form needed? You can submit a PA correction form whenever a PA correction is being requested. To get the form, you can go to the Access website. I have listed the website where you would be able to find it. It is under the prior authorization forms tab. With the corrections, if you can just upload the provider quote along with it. Next slide. As for the PA forms, if you could please fill out the PA required fields. Not doing so will result in misfiling of PA requests. So I did put an example of just what has been coming in with it not being submitted correctly. Return faxes. I have received some emails regarding the return faxes. If you aren't using the correct PA forms, or if they're not filled out correctly, you may receive a letter. This letter is automated from the scanning department. They do not give me notification if they're rejecting or returning your faxes. So sometimes I do get an email saying we're getting a return fax email. That does not come from me. It comes from the scanning department. Again, if your form is not filled out correctly, or if they're not able to locate where your request is to be going, they'll return it. Sometimes if it's a little slanted, I think maybe that could be a reason, because I have seen somewhere the form is just kind of old and weathered looking, where it was rejected. But again, I just want you to know that this is an automated letter from the scanning department, and I would just, ensure that your fax form is filled out appropriately so that they are aware of where your request needs to be filed. Common PAs not required for acute or long-term care services. I have received some that do not require PA. This was a little, so home services, I don't send out PAs for. I have received some of those. Supplies under $100, DME supplies over $500 in purchase, hospice services, transport services, therapy services, SNF levels 0191, 0192, and 0193s. Pharmacy, if you get any pharmacy requests, please send the medication request form directly to Optum. Please complete this form and fax it to the Optum RX number 1-866-463-4838. If you have any questions regarding this process, you can contact the Optum's RX customer service. And their number is 1-855-577-6310, and I'll update that slide so it is visible. Here is my contact information. If you have any questions, you can call or email me. As for the questions I have on here, let's see.
The first one, Vanessa, was can a family nurse practitioner, their signature and credentials be used like for home modifications?
Right now with the PHE, they did extend the providers that can sign for it, and right now I am accepting them. And
thank you, Vanessa.
Mm-hmm.
And then there was another one in the queue. It says, what about the surgical procedures prior authorization is telling the physician's offices that ALTCS are to enter the procedures?
For the acute surgical procedures, those do get medically reviewed. The providers, I had one case come up where the acute side did send the notification to the provider where PA was not required for the surgical procedures. I have not heard of any other ones that have received that response. But if you do get that type of statement from the provider, if you can send me the information so I can look it up to ensure you that there is no PA request that is needing prior authorization.
Thank you. And then there's one more regarding also, is this also DME's prescriptions? Can you be a little more specific? Are you still talking about which medical professional can sign the DME prescriptions? Yes. Can a family nurse practitioner sign the DME prescriptions?
They can, as long as that nurse practitioner is under their PCP. So if that nurse practitioner is also in the same clinic as that member's primary PCP medical provider, then they can. I know that's kind of hard because sometimes the IHS facilities have nurse practitioners that are like filling in.
Yeah, historically, it has been challenging for Indian country because of the IHS 638 facilities. A lot of the locums are only there temporarily. They don't have those kind of, what do they call it? Like in the urban setting, when you can have a physician be co-signing for you when you're not a physician, that your PCP is the only one that has that credential, I guess, in that facility, something like that. So I think that it still seems like a challenge for them. But again, as Vanessa stated, through the PHE, those scripts are being accepted if they're signed by the family nurse practitioner. Any more questions for Vanessa? And again, her information is there on that last slide, and I'm sure you have that. So thank you.
Do we have any
Okay,
more
thank you,
slides,
Vanessa.
Charlotte? Yay. Okay. I don't think you guys put anything together, right? Because I know Cheryl's kind of been trying to hold up both sides as Vandana was trying to let go of her previous responsibilities. So we've been really just trying to focus on getting these PA requests through our systems and get them approved for members if we do receive them. And then also following up on member issues and concerns that we've had. So the overall presentation that we provided to you today is basically what we have seen since we've incorporated that data sheet that we put together. And again, that data sheet that Vandana had presented, there's additional sheets for that. Each one of those sheets are spread out by the different offices, especially with Navajo Nation. I know they have multiple offices, and also Paspeaki has 2 offices. So we now have the capability to monitor at the office level and drill all the way down to the specific case manager level. So that really does help us to provide assistance. So we're looking at some of this information. We're also looking at the data that we receive on that report. Also does help us to identify what we're going to see when we go out to audit. You know, what are we going to be, what do we run the risk of running into? Is there any way that we can provide some sort of assistance to the tribal ALTCS program as a whole, or as an office level? What do we need to provide education on? Because your scoring does impact what type of support we provide to you. So we are just as accountable. I hold my team accountable for anything that shows up on the report. So that is the reason why they're sometimes put on special projects. You know, when I do see something that just doesn't look right, or when we start getting complaints or concerns, then we utilize those reports to actually pinpoint what is going on. So that's one of the research that Cheryl was talking about, of utilizing that dummy code, of members being placed in utilizing that dummy code with the S5125, but there was no justification on the CA165 to let us know this is what's going on with that member. So it really, those reportings do help us to kind of provide these types of education to you all, and do some of, you know, a refresher. I know some of you probably look at those policies, you know it in and out, but there are a few changes that happen. Really, they're not, a lot of them aren't really drastic change, but there are changes that do happen within those policies, ensuring at your own internal office meetings, educating and bringing up those policies, referring back to those policies. We try to stay in line with the policies, so we don't have to create so much. Like, we've gotten rid of the case management manual by looking at the policy and saying, this is in line with what we do. This is in line with what the tribal ALTCS case managers do. I remember, I think it was 1620F was the only one that was really tribal specific. We've updated that to align with some of the processes that you all have been doing. And we've really been advocating on the tribal ALTCS side to say these are the barriers, these are the challenges, and that data report really does help us also to justify our reasoning. If there's a barrier in obtaining a service, a provider, we always ask for data. What research have you done at the tribal level? And then we can, bring it back. Our internal team does additional research. If we do find and conclude that there is no other option, there is no other service, and some of the issues and the barriers that the tribe has came across, we do advocate at the higher executive management level and say, look, these are what our programs are running into. It's going to cause a quality of care issue. So to just kind of give my team kudos, they were the ones that really helped to develop these reports. These reports are more live reports, more data report. They can go into a system that we've created where a system that's created where they can actually pull these reports daily. So if your case manager got a call about an overdue yesterday and the case manager, they're following up 2 days later, there was no changes, they can run that report and see that that member has no update on the service plan, or they can actually tell when it was updated. So that really does help to provide that additional support to your case managers and you as a supervisor. So we are geared towards more data collection, so that way we can at least be of more support to you all and give you the heads up on, hey, this needs to be done. It's not to bug everyone and to harass anyone. It's basically to help so that we're helping you all to coordinate that care that the member needs, or we're helping you all to advocate for the member's need, because we all know that our members, many of our members live in such, rural areas. And I always make that an example. You're the voice. Our case managers are the voice. They're the first point of contact. They trust the case manager. They build a relationship with the case manager. They tell the case manager sometimes their whole life story. They know everything, pretty much mostly everything, especially with the elderly ones that really don't have, visitors out there. So that really does help out when that case manager is so heavily involved. And it's a lot of responsibility, and it's kudos to them too, because they make it happen. And you all leading your team, and we really have seen so much progress. We haven't received no pushback. We're, like I said, my team is here to support your team members, you and your team members. If we do see something, if we do come across an issue, we'll try to work very closely with you and ensure that you obtain the skills that you need as a leader to be able to provide that support to your team member, because at the end of the day, it does impact a life. It does impact a person who really does need us, that sometimes in some point in time, they might not be able to advocate for themselves. So I appreciate everything that you all do. You guys are, or you ladies and gentlemen are the main point of contact, and we appreciate everything that you all do for us and out there for our members also. So thank you so much. If there's no other questions, no other concerns, please, don't hesitate to call if you ever have any issues. And also please share your information, your contact information with your case. Have them share that with your members. So if there's any complaints, you all are handling it internally, documenting what those complaints are and the actions that you've taken on your part, so that way it doesn't escalate up to our level, so that way we can see when we do audit that you are handling those cases also. And just remember, case managers always have to remember to be member focused, as members have rights. And I think once that continues to get communicated, overall, I think it'll positively impact our members and the care that they receive. So thank you so much.
Thank you, Rachel. Lorinda asked a question about being quizzed on the digital toolbox with information put on there. I'm not sure, so I need more clarification of that, Lorinda. You can put it in the chat if your speaker isn't on.
Lorinda wants to be quizzed, I think.
I think so.
Well, it was just brought up at one of our conversations that any information that gets put out onto the digital toolbox, that that we should always check that and make sure we familiarize ourselves with what's being put out there. So I was just checking to see if that was relate to all the tribal contractors. So that's just my question on that.
So I think that was interpreted unclearly. It's not having to do with a quiz. It's about ensuring that every supervisor, every tribal case manager goes into the toolbox to know how to navigate that, to know how to look at the different areas. And it was regarding training. We had originally said that we were going to start uploading our trainings onto the digital toolbox, and we were working on a way to be able for all case managers to go in there and possibly take a post quiz after the training, so that you guys as a program can have that as record that you are doing training. Again, as Rachel stated, every tribal program can bring your own trainers in within your communities, maybe somebody to do diabetes signs and symptoms, or somebody from your HR can come in and do your annual HIPAA training. Those are the responsibility of each tribe to keep track of it, so that at some point when the operational review starts to check your training programs within each office, that you maybe have some kind of binder of records that your staff have been trained on. So that's the explanation of it. It's also about competencies. We all have to ensure that we keep up our competencies, whether it's our own desire to take free webinars, to go to certain trainings, to obtain higher education. That's all personal choices. But we also want to ensure that we all continue to keep up and increase our knowledge and skills within tribal case management, access policy, Medicare. And that's why as Access, that's our mission with these quarterly trainings, is to see what's trending across the board and try to improve the training knowledge in those areas, and then also up at the higher elevation, update policies. Thank you, Lorinda.
So to piggyback off of what, I know Yvonne has her hands raised too, but to piggyback off of what Cheryl had said, yes, we have mentioned it in these quarterly meetings in the past, where we have said, yes, we're going to start posting more information out there in the digital toolbox that will help the case managers. It will help the supervisors. Say if the supervisor is not available, they can refer their case managers to the digital toolbox. And once we get that working and updated, we're planning on coming up with some sort of quiz that that you can refer your case managers to, and maybe even utilize that internally to know what the knowledge of your case manager has, and then utilize that tool to be able to provide additional training if your case managers need it. You know, I would, you know, confess too that not every area that my team does, every area, I'm not a professional in it, and I can admit that, and I do need assistance and I do need help sometimes. And that's where I have to continue to read these policy. I have to continue to be engaged so that if my team members need me, I'm able to provide that support. So the test or the quiz is not to, anything that we present to you all is not to create that I got you moment. It's basically to help you, whether you want to grow and know more about the program and the population that you serve in your community. I've always have stressed that these are our tribal members. Each one of the case managers that applied for the job or supervisors that applied for the job, everyone, they all know what is expected of them. And then of course, we all have to go back to how would we want our loved ones to be treated? How would I want to be treated? I'll be elderly one day, and how would I want to be treated? And these are some of the things that we really try to incorporate and say, hey, look, these are some useful tools that you can use on the digital toolbox. And we can add quizzes if you need us to add it, or you can create your own quiz on your side. You can create things that will help you and your team members and identify where the need is at. So yeah, once again, I do appreciate that, comment that you put in there, Lorinda. In future, we're hoping to get a quiz created where your team members, you yourself and the team members can complete.
Thank you, Rachel.
Yvonne, you had a question?
No, I just have a comment. As a nurse consultant, I review charts for San Carlos program. And as a nurse, or I advocate that if there's a nurse in other program, that really helps enhance the person-centered service planning, because reading the notes and reading the forms that you have, that 28 pages form, that has a lot of information in there, and it gives me an idea of what the person really needs in the aspect of their diagnosis and their physical being. And I will tell the case manager, kind of watch out for this and that. And it really focus individual on the client. It's most hospital now, when you go in, it's one fits all. If somebody's a diabetic, then everybody gets the same diet, but it's not true. It all depends on the individual, how they're doing in their diabetes, and also what the diagnosis. And the other thing I do want to say, what you said, Rachel, is that it's a population, you need to look at it, and the case managers should know all the population. I am not only the case manager, I carry many hats here. I am now delegated to emergency preparedness and emergency response. And I've been going to the state level on the emergency response preparedness commission. And I was just surprised that the individual, I think they would have thought about ALTCS, because the case manager knows the people who needs the most help during an emergency. They know the clients that if what they can do, what they cannot do in emergency. They know where they live. And I had to do a lot of education to the members of the state level that what ALTCS do. And I was so surprised that they didn't know anything about ALTCS. And I do advocate that if there's an emergency in your community, please contact the emergency and let them know to help your clients to be prepared for emergency, or be prepared if they need an evacuation. And it goes even as small group as the Tribal Arizona Emergency Response Commission. They too did not know anything about their ALTCS members. And I was just shocked that they should know that, because the ALTCS members are vulnerable people. That's why they come to us for help and everything. But when there's emergency, case managers know exactly what needs to be done when there's an emergency So I just want to advocate and just let everybody should know that when there's emergency in your community, please get in touch with the people who's head of the emergency, because you can really help. You can really help everybody, not just ALTCS, but everybody else, to let them know how many is disabled, how many needs special equipment when transfer. And I know here at San Carlos, when we had an emergency with the fire, I was just appalled how they forget about the dialysis clients that need to be dialysized, and there has to be a planning station to transfer them out. And that's how I feel about ALTCS. It's a very important program for our population, especially for the tribal members. Thank you.
That was awesome feedback, Yvonne. Thank you.
I do have to say, I do have to commend all of you though, because anytime that there's a fire, a flood, or whether it's related to the temperatures, the weather, I would honestly say that everyone is always on it. They're already in the know. The tribe is already doing something. You know, the leadership would tell us, hey, reach out to the tribe and tell them that this has happened. They need to do this. And once we do the outreach, you know, we get feedback right away. Not only are we doing that, but we're doing this too. And so, you know, I really commend you guys for doing that. I know that you all utilize the resources out there. You're at the leadership level, have a lot of knowledge in what's going on with the community and where the resources are available at, so that you can at least coordinate those care or services, or even just the transition of a member from one location to another. So that really does help out. And I so, you know, I really appreciate all of you all for that. And you do a lot. Your team members do a whole lot that sometimes I'll make you guys the example all the time. And we have a team member here that's, she's a healthcare coordinator for the DDD side. I'm always bragging about my tribal ALTCS program, the case managers, the program as a whole, the work that you all do with the limited and sometimes limited resources that you have. The work, the outreach, the dedication, the coordination of care. You go up, your case managers, many of them go above and beyond. And I always express it at the state level to let everyone know, even to other agency, and say, this is what my tribal ALTCS programs, they do. This is what the leaderships do. This is what the case managers are responsible for. So I do appreciate everything. It's just not at the level here that we talk about you, but, you know, but I always, you know, brag about all of you. So just keep that in mind, that even though you may think that somebody doesn't know, trust me that they do know. Honestly, we're advanced in all of our reporting that we do relating to this population. So we are within our division, we have reportings that are to today, that we can actually look at it and say, this is what's going on. So, but the only thing is, your case managers have to keep the system updated, keep the PMMIS updated, so we know that, yes, whatever they're putting on there is up to date. We can look at it, we can pull it, we can see it and say, yes, that's what's going on. So, you know, and it's all, you know, their work and what they do, and what you as a leader, how you guide them. So use these resources that we provide to you to provide that additional training, education, expand their knowledge, and speaking up as a program leader, you know, like Yvonne just mentioned, those are some barriers. Those are some issues that she's seen in the tribal community, how she reacts, how she advocates. You know, it just takes that one voice to make a difference. So continue doing that, continue advocating. I know Rydell is a really good advocate in the tribal community with White Mountain. And I know every single one of you, Lakeisha, I know she's brought a lot of her expertise to Gila River, you know, the new people in with Native Health. I mean, everyone brings something to this, and I really do. If it wasn't for you, it wouldn't be where we're at right now. There was resistance at first with the reporting, but now everybody's utilizing that tool to ensure our members receive the services that they need. So thank you again. I don't have anything else to cover, or if there's any other last comments or closing comments, you're welcome to do that now. But if there's none, we can go ahead and close out this meeting.
Thank you. I just like to say one more thing that was a good segue into the screen that is currently up. Please do, all of you tribal programs, start looking at all the different recognitions or highlights of your tribe that since COVID started, and submit them to us so that we can, put them and recognize the plans in our quarterly meeting. So the next quarterly meeting, let's go ahead and look into getting some of the highlights up here, because a lot of times, we don't hear a lot about it, but we'd like to be able for Rachel to take it up all the way to our executive, our director's office to show what's been happening out there. So thank you, everybody. Thank you very much. If there aren't any questions, then that concludes our meeting.
Thank you.
Thank you.
Thank you.
Have a good evening or day.
Have a good one, everyone.
Thank you.
If my team can stay on so we can recap. You can stop the recording, Charlotte.